everyone, followers and readers of Arab Hospital magazine. Today we are pleased to present to you, with the collaboration of Boehringer Ingelheim, a new session entitled The New Era for Reno-Cardiovascular Treatment in Type 2 Diabetes. We are honored to have with us Dr. Hiba Barghouti, Clinical Director, Department of Nephrology and Hypertension at Abdallah Hospital and Medical Center in Amman, Jordan. She's American Board Certified in International Medicine and Nephrology and a member of the Board of Directors of the Jordan Society of Nephrology and Renal Transplant. Welcome, Dr. Hiba. We are happy to have you with us.
Thank you. Thank you.
So, also we are very honored to have with us Dr. Rula Youssef Ghoussous, trained in internal medicine and endocrinology. She joined King Hussein Cancer Center as an endocrinologist in 2005. Currently, she leads a joint clinic where her main focus is thyroid cancer and abnormalities, dyslipidemia, and diabetes. Welcome, Dr. Rula.
Thank you.
So I'm going to start my first question with Dr. Rula. Dr. Rula, we used to think that type 2 diabetes patients should only focus on monitoring health glucose level. But today we know that people with type 2 diabetes have higher burden of comorbidities and risk factors like heart diseases, kidney disease, obesity, hypertension. So what can a patient do to avoid having these complications? And is it possible to avoid them, or the patient is sentenced to have them during his life with diabetes?
Well, this is a very actually valid question. Just like you mentioned, diabetes is not anymore about hyperglycemia and elevated glucose levels. Just like you mentioned, those who have diabetes are at risk for high blood pressure, at risk for high cholesterol. Most of them are smokers. Most of them are obese. And this makes them carry a big burden of comorbidities, especially cardiovascular disease and renal failure. So to be honest with you, patients should know about this. They should talk to the doctor. They should come to the clinic, because diabetes is not just about writing medication to control blood glucose level. They have to prioritize cardiovascular health. We have to communicate with the primary care physician so that he can communicate with the patients regarding such cardiovascular, renal complications, and so forth. Yeah. This is quite important because we can actually prevent such complications. Okay, so we can tag who is at risk for such problems, and we can prevent such complications. And if we control the glucose levels in the blood, and if we control cardiovascular risk factors, and if we, as we're going to come along and talk about other medications, if we can do all this, then we can definitely and hopefully prevent cardiovascular disease, renal complications, and other comorbidities that diabetics can experience.
So a type 2 diabetes patient, when he discovers that he has the disease, he should be immediately at an early stage treated for other or like cardiovascular risk factors. They should be treated immediately, or you can wait until he has some complications or symptoms maybe.
You know, Mirna, cardiovascular disease is the leading cause of death in diabetics. Up to 70% of deaths in diabetes is secondary to cardiovascular disease. So definitely they have to be checked. And this is more important because diabetics have raised threshold pain and they have reduced nerve index. So they could have a silent heart attacks, silent myocardial infarction, and cardiovascular disease. So of course they have to be checked. Okay. And they have to be checked early because people with diabetes could present, upon presentation could have a cardiovascular disease. Actually, 70% of those with myocardial infarction / heart attacks, 70% of those who present to the cardiologist have diabetes type 2. And 50% of those do not know that they have diabetes. So Upon diagnosis of diabetes, you already can have cardiovascular disease. And upon presenting with myocardial infarction, you could be diagnosed with diabetes.
Okay.
You know that every 5 minutes, someone with diabetes gets myocardial infarction. It is vital, of vital importance, that patients should be checked and as early as possible.
Okay, thank you, doctor. So, Dr. Hiba, why type 2 diabetes can lead to kidney diseases? This is my first question. And what is the relation between these two diseases?
Thank you, Myrna. Well, the relation between diabetes and the kidney is very well known. And I'm going to take a step back and just tell you about the kidneys a little bit and then the relationship. Let me start by saying diabetes is the leading cause of kidney disease worldwide. If you look at the world as a whole, there are around 4 million people requiring dialysis. But there's a lot more patients, around 850 million people with chronic kidney disease.
Yes.
If you go to a dialysis unit with 100 patients and ask them what was the reason for your kidney failure, 30 to 35% of them will tell you it's diabetes. The number 2 cause is hypertension, and many diabetics have already hypertension as well.
Yeah.
We have 2 kidneys. Each kidney has a million filter called nephron, tiny filters. These filters, they work hard to clean our system from toxins, extra fluids. They work on controlling your blood pressure. They work on your bone health, and you're producing red blood cells. If you have a risk factor, these nephrons can take it and they can work hard year after year after year. But at this one point, they fail. When they fail, it causes kidney damage and kidney disease. The sad part about it is most of the kidney diseases are silent.
Yes.
Diabetes affecting the kidney, causing slowing down of the kidney function, and then damage of the kidney is completely silent. You can lose 90% of your kidney function and have absolutely no symptoms. When you have symptoms, you're already late. And that's the importance of such educational sessions. The diabetic patient is not about a number and not about his kidney number or his sugar number. It's approaching him as a whole, his heart, his diabetes, his kidneys, his eyes, his blood vessel. Diabetes is a syndrome that affects blood circulation everywhere.
Yes.
So again, diabetes is the leading cause of kidney disease, and the correlation is very, very obvious. Screening all diabetics for the presence of early kidney disease before they have absolutely any symptoms is very crucial.
Crucial, yeah. So, and what is the role of the nephrologist in the treatment of patients with type 2 diabetes and its other conditions?
The role of nephrology, first of all, is educate primary care physicians and general practitioners that the correlation between diabetes and the kidney, because there are a lot of patients with diabetics. Not all of them need to see a nephrologist to start with, but they all know their numbers.
Yeah.
I like this title, Know Your Number. What do we mean, know your number? Know your number, know what's your blood pressure. Know your number is ask your physician, how much are my kidneys working? Because there's a test in the blood called creatinine. It reflects how much your kidneys are working. The lower the kidney function, that means you're advancing in your kidney disease. But most importantly, Myrna, and this we see it every day, Ruda knows about it, is a patient can go to the lab and check his numbers, and it's absolutely fine, but still he has kidney damage, because the first sign of a kidney damage or kidney effect from diabetes is through a message through the urine. So a urine test checking for a protein or albumin is the first screening test to check if your diabetes has started to affect your kidneys or not.
Can you tell us a little bit about the numbers? I mean,
correct. Very good question.
Yeah.
So this is the triad of your kidney health. Your blood pressure. All the risk factors that can affect your heart are the same risk factors that affect the kidney. Diabetes.
Yeah.
high blood pressure, obesity with all its complications, smoking, high cholesterol, or having a family history of heart disease or kidney disease. Know your number is the following. When a doctor or a nurse checks your blood pressure and she tells me, oh, it's okay, ask her what is the number. Why? Because you may be living with a blood pressure of 110/80, and all of a sudden it's 140 or 130. You need to know the difference. What's your baseline? What's your normal blood pressure? A lot of people live with low blood pressure. In diabetics, especially with some kidney disease or protein in the urine, we like to keep their blood pressure lower than other high blood pressure patients. Like 130/80 is the maximum that is allowed. The other number is demand what is my albumin in my urine. This is called an ACR, albumin creatinine ratio. This is the first message that the kidneys send to us, telling us, be careful. I'm tired from high sugar or high blood pressure or smoking or obesity. The normal number is less than 30. Ask your doctor, have you checked for an ACR? The third number is a blood test called creatinine. Creatinine is a normal material that our body secretes, comes from food, from the muscles, and the kidneys get rid of them. Normal creatinine is less than 1, around less than 1. If it goes up, that means it's abnormal, and there are stages for kidney disease, stage 1 till stage 5. If we start treatment and risk stratification and risk management at stage 1, it's much better than stage 5, which is already the damage is there, and we have lost more than 85% of the kidney function. So the three numbers, every patient, regardless of why he's in my office, needs to know them by number, because he needs to be advocate for his health, and he needs to tell this piece of information to his physicians in a year or two. If he knows his baseline, it's very, very helpful.
And Dr. Roula, what about the numbers of the level of glucose in the blood also? When we consider a patient a type 2 diabetes patient, or when he is still in the pre-diabetes phase?
It depends on two important blood levels. One of them is the fasting blood sugar. The fasting blood sugar should be below 100 for every individual on earth, okay? From the age of 1 year till maybe the age of 100. When the fasting blood sugar is between 100 is included, and 125, he's considered to be a pre-diabetic. And the higher the number, the worse is the scenario. Now, once the blood sugar, the fasting blood sugar, fasting meaning fasting 8 hours without food or drinks except for water, no need to fast for 12 hours. If the fasting blood sugar on 2 occasions is 126 and above, this is by all means diabetes. Okay. Now, there's another test that's very important that's new relatively, which is called the average blood sugar control over the past 3 months, which is what we call HbA1c.
Yes.
Now, for normal people, it doesn't matter male or female, it should be below 5.7%. Now, 5.7 to 6.4% is pre-diabetes. And of course, once you hit 6%, you need to be quite aggressive, because we can do something to prevent diabetes, quite aggressive in regard to therapy. 6.5 and above is considered to be a diabetes. And this is very important because patients think that 6.5 is okay. They think that fasting blood sugar of 130 is okay. No, this is by all means diabetes. Sometimes we don't need to do this. It's a hassle. We give the patient a drink of glucose and water, and we check the blood sugar after 2 hours. For such patients, the blood sugar should be over 200 and above for it to for that patient to be a diabetic. Okay. This is like a very easy way to remember it.
So, Dr. Roula, what are the latest recommendations in treatment of type 2 diabetes, and how do you decide to integrate the treatment with the other doctors like the cardiologist and nephrologist?
You know, Mirna, 20 years ago, we only had 2 brands of anti-hyperglycemic agents to treat our patients and insulin. Now, we have a breakthrough in the treatment of diabetes, and we have many more medications available in the market. that actually are of quite importance because they go beyond glucose control. These agents, they can tackle cardiometabolic and cardiorenal disorders in diabetics. They can do this in addition or independent of blood glucose control. So these are integrated now in the guidelines. And just like Dr. Heba said, the link is very important between, the diabetes and kidneys. The link is important between diabetes and cardiovascular disease. It's sometimes cardiologists tend to say that diabetes is a vascular disease, that it's even their specialty, not our specialty. In some guidelines, we say that diabetes is coronary artery disease equivalent, meaning it's a cardiovascular disease equivalent. So knowing this and knowing that 20 millions globally die from cardiorenal metabolic disorders combined all over, knowing this, I think that first of all, we, meaning endocrinologists, nephrologists, cardiologists, and do not forget primary care physicians, should all be on the same page, communicating the same message for patients, that diabetes is not about blood glucose levels, it's about everything else. It's about, like Dr. Heba said, it's a holistic approach to the patient. And nowadays, because there are new agents in the market that can tackle cardiometabolic renal disease and disorders, they are now first in line for treating diabetics with cardiovascular disease or renal disease. It's not one size fits all as before. It's for every individual. We should individualize treatment, and knowing that these new medications could actually make a difference in the life of a diabetic.
So, Dr. Hiba, what is the importance of educating the patient about what Dr. Rula was saying about the cardiorenal metabolic risks, and how is it possible to do it with the patient?
No, it's very possible, and I think as we all agreed, this is a teamwork when we're approaching a patient, and the center of this team is actually the patient. We really need to know his lifestyle, his preference, his support, so he can be part of this approach. Educating the patient that absence of symptoms, if you have no symptoms at all, doesn't mean doesn't reflect your kidney health. You really need to check. Educating them about the link between heart, diabetes, and kidney. So he knows that every year, even at a very early stage, he has his annual checkup with his kidney doctor and with his heart doctor is very important. Educating him about the number and the importance that even a blood test is not enough. And for him to advocate for this to be done is very important. And more importantly, besides the medication that we're going to talk about, the lifestyle changes. We cannot underestimate diet, exercise, smoke cessation, and the healthy diet, because this is the mainstay of all the guidelines. Start with lifestyle changes, because these are all going to reflect into a better kidney health, better diabetes control, and cardiovascular protection. And then we'll ask ourselves, what's more can we do on that? Patient is the center of this team, and he needs to take the lead, because once he knows how he can help himself, that will reflect, he'll be compliant on medications, he'll understand why he needs to do these tests every 3 or 6 months, and he'll be very, very meticulous about following up and checking on his kidneys and his heart.
Dr. Rula, do you think that at an early stage of type 2 diabetes, can lifestyle changes only be the only treatment for the patient without medications at an early stage, I mean?
Mirna, we are now using medications to prevent diabetes. So at an early stage of diabetes, definitely, we cannot underestimate what Dr. Heba said, that lifestyle changes are very important, but they're not sustained. okay? And that's why we need medications. We now give medications to prevent diabetes. So when someone is diabetic, we need to hit it strong. We need to treat right from the get-go. We cannot just depend on lifestyle medications.
So, Dr. Hiba, we know that over 50 treatment guidelines worldwide endorse type 2 diabetes treatments with cardiovascular and renal benefits. Can you tell us which ones are the most effective now in the treatment of this condition?
Well, Mirna, I have to say 2020, with all its challenges, has been really fruitful for the field of diabetes and kidney disease. For the first time, the strongest kidney authority called KDIGO, which stands for Kidney Disease Improving Global Outcome Guidelines, they published their guidelines about treating patients with diabetes and kidney disease just a few months ago.
Yes.
Now, why? Because now we have something different and something else to offer our patients. I think the question that our patients still ask us, and we have to ask ourselves, is not how to bring this number down or to bring the albumin down. The two vital questions: is this medication going to help my heart and reduce my risk from heart attacks and strokes? And are you going to protect my kidneys and give me more time without reaching dialysis? These are the two main questions after the screening and education and the lifestyle medications. We had many medications before. They used to bring the numbers down. None of them, except maybe one, really it was proven in repeated studies containing hundreds of thousands of patients that they can reduce cardiovascular events in our patients and can slow down kidney disease and extend the time for any kidney patient to reach dialysis. So KDIGO, which I told you, the nephrology guideline, says that the first line of treatment for any kidney patient from diabetes needs to have lifestyle modification. The second line of treatment is a dual therapy using an old-fashioned, lovely medication that we all adore called metformin, and a new class of medications called SGLT2 inhibitors. From the onset, you don't wait till you start with one and then you add on. Two together as a first step after lifestyle modifications. Why? Because we're not going to wait for diabetes to cause complication and then start act, because most of the damage when it's happening, it's irreversible. And these classes of medications are not considered purely anti-diabetic. These are heart kidney protective medications. We add them regardless of the diabetes control, just to protect the heart, protect the kidney, and give our patients a longer, healthier life. So this is the KDIGO guideline, two medications together from the start, including the old-fashioned metformin and SGLT2 inhibitor.
So, Dr. Rula, we sometimes know that one medication for diabetes doesn't lower the glucose level as the doctor wants. So he have to use many, maybe one or two or three medications to help the patient lower his glucose level. Is it true?
It's more than true. I mean, we use metformin, the medication that Dr. Hiba talked about, to prevent diabetes.
Okay.
So when the patient comes with diabetes, metformin alone will not do the job. Okay. We need something in addition to that. Now, we have to know that just like treating diabetes and all, this holistic approach, that I just don't want to lower the blood glucose levels, okay? Earlier, in the past, we used to lower blood glucose levels, and we used to reduce the cardiovascular renal risk factors by controlling blood pressure, controlling cholesterol, stopping smoking, weight loss, healthy lifestyle, and exercise. Nowadays, with the new medications in the market, with the new kids in the block, the SGLT2 inhibitors that Dr. Hiba mentioned, and the GLP-1 analogs. With these two medications, we can actually, I mean, they have taken us beyond risk factor modification. They have created a paradigm shift in the treatment of diabetes, that we just don't want to control blood glucose. We want to control cardiovascular risk factors and renal disease and metabolic factors and so forth. And so that's why it's metformin with either SGLT2 inhibitors or the injectable GLP-1 analogs, and then we go from there. Patients, sometimes we give the patients such medications not because we want to lower their blood glucose levels, because we want to go, just like I said, beyond risk factor modifications. And we want to control their cardiovascular disease and renal disease, because they do have a great impact also on blood pressure, on weight, and so forth. So treatment guidelines have changed all over. And so hence, we as doctors should also change. And this should be applied to all patients, actually, all over. It's their right to be treated well.
Yeah. So it's a great news for the type 2 diabetes patients, because before the complications were so many for the diabetes patient that has diabetes, for example, for like 20 years or 15 years. So this is great news for them. Dr. Liba, is there any treatment that can reverse kidney failure or can help stop the deterioration? Because we know that when you tell a patient that he has kidney disease and his kidneys are not working properly, he panics, because we all hear that when you start having kidney disease, you can never go back. So what can you say to kidney disease patients?
Yeah, very interesting question. Thank you, Mirna. So remember when we said that there are 5 stages of kidney disease. Stage 1 is actually reversible. After that, it's not. Stage 1 says we have absolutely normal kidney function, but protein in the urine. So we've picked it up when the kidneys are still working 100% or 90%, but they're showing evidence of beginning of a damage or beginning of a inflammation. And that we're talking about diabetic kidney disease. We're not talking about kidney disease in general, because they're completely reversible kidney disease in different than diabetes, like acute inflammation. This is irreversible. So we're talking about kidney disease from diabetes. Stage 1, and that's why it's very important. Screening programs means your kidneys are working, your blood tests are normal, but your urine test is abnormal. If we work really hard at this stage, and there's no magic bullet here, there's no magic pill, we have to be clear, and Rula agrees with me, these medications are not magic. This is hard work everywhere. If we start at stage 1 of kidney disease by modifying all risk factors, diabetes, smoking, weight, blood pressure, and having the right medication for that individual patient, you can reverse kidney disease. Mm-hmm. The more we progress towards stage 2, 3, 4, and 5, we cannot reverse the damage, because kidney cells, once they get damaged or they die, they do not regenerate, unfortunately, like the liver and our cells. Yeah. The other cells start to work harder and harder, and with time they fail. We can slow down, meaning rather than a patient reach from stage 2 to 5 in a year, we can extend this to 5 years, hopefully 7 years and more. And again, and that's why we really have to start very early, and we have to focus on screening to detect patients at a very, very early stage, preferably even before the kidneys got damaged, with good control of all the risk factors.
And for both of you, what about the role of the nutrition in this? Dr. Rula.
Nutrition, it goes hand in hand when it comes to treating diabetes, because patients, in general, humans in general, are not really very much aware of the kind of diet that they have to eat. Mm-hmm. And early on, when they become diagnosed with diabetes, they become so excited and they become so determined to cut down on sugar and carbohydrates and bad food and so forth. But it's not sustained.
Yeah.
So I try to tell them that this is a lifestyle changes, and that, you know, it's always good to talk to a nutritionist, so that she or he can guide you on the right ways to control the diet. So nutrition is very important, especially for diabetes. Diet plays a major role when it comes to diabetes, you know, and especially we're talking mostly about type 2 diabetes. Patients here are quite obese. Type 1 diabetes, where they have to take a lot of insulin, they have to calculate, you know, carbohydrates, to do carbohydrate counting. So nutrition is essential. They need to be educated about the dangers of high salt intake, for example, you know, about the diet high in sugar and carbohydrates. I believe it's essential. For me, they go hand in hand when I see a diabetic. Just like I tell them that they have to be screened for cardiovascular disease and screened for kidneys, I always say that they have to visit their dietitian, even if they're thin, to know it's not about losing weight only. It's about changing your lifestyle whole in whole.
The kind of food you are taking.
Yeah.
And also, Dr. Hiba, we know that nutrition has a very important role in protecting the kidneys. Isn't that true? And it helps the patient also?
Absolutely, I agree with Rula. Diet and nutrition goes hand in hand with all the conventional steps that we've mentioned. Actually, dietary consult and guidance goes parallel with my clinic all the time, because it's very important. There is different restrictions and different diets depending on the stage of kidney disease, but preferably a proper nutrition and a healthy lifestyle can actually start for the general population to prevent the diabetes from happening and kidney disease. But in our kidney patients, different stage has different modifications, and this is tailored to the patient weight, the stage of his kidney disease, the underlying cause. So this should be individualized. And mainly we're talking about salt restriction and animal protein restriction. And these are the two key components in kidney-friendly diets.
So, Dr. Rula, what is the importance of knowledge, and to what extent do we need to raise public awareness regarding this serious matter? And what are the ways to raise this public awareness? Is it the role of the government? Is it the role of the doctors only? So it's
knowledge is power.
Yeah.
And unfortunately, though we talked about cardiovascular disease being the leading cause of death in diabetics, and being the leading cause of renal failure in those patients who are in dialysis, but I believe that patients don't even know this link. They don't know about it. And this knowledge gap points out to us that we have to go out there and raise public awareness about such a problem. Patients, when they come to me now, just now diagnosed with diabetes, the first thing that they would say to me, I promise you, I'm gonna lose weight and I'm gonna cut down on sugar and carbohydrates, and I'm gonna come back to you looking really good with an average blood sugar control that's perfect in 3 months. And I try to tell them that we have to look beyond that, okay? I tell every patient that they have to be screened for cardiovascular disease, even if they don't have any symptom. Just like Hiba said, it's a silent cardiovascular disease. It's a silent kidney disease. They have to check their eyes. They have to check their teeth. We have to do the special urine test for the patients. So talk to your patients. That's number one. Number two, we can raise public awareness by the power of social media. Okay, this is very important. We can reach the patients by Facebook, WhatsApp, Twitter, YouTube's online videos. We can work with associations, small associations, to conduct workshops and presentations and lectures for the public to know about diabetes, because every time I present to the public about diabetes awareness, I find so many patients will actually go to the doctor just from a simple message that they have to check for diabetes. They would actually go to the doctor and be checked. So, you know, nowadays, life is too easy. It's very easy to send your message. Nowadays, with the social media effects, it's very easy to send your message. So I believe that we can do such a thing when it comes to educating the patients about such a problem.
And Dr. Hiba, do you think that the government should have a role in this? And do you think education, health education, should start from schools?
Well, as Rula said, knowledge is power, and but this is a double-edged sword because there are a lot of also faulty resources for knowledge. So we're seeing actually some negative impact of social media. I think it's support from everywhere. We can work on individuals, physicians, and we can work on a higher scales. Like, of course, school is and universities are really good resources where we can start giving small, simple pieces of information, and actually we can work by preventing diseases rather than screening for diseases. It's prevention when you start at early stage.
Yes.
I always say our patients and people we deal with are smart. They listen. We only have to open these channels of communication and give them enough time. We should give them the right to say this medication or this thing, I cannot do it. And it's my responsibility to adjust to their needs. And I think communication and more time with the patient is very important from the physician point of view. From a society point of view, media, screening programs, and TV and social media, as Ruda said, is of paramount important to give the right medication, right piece of information in a very simple way. We can prevent diseases, we can control diseases. None of us are here to make patient afraid to be checked. We want them to be healthy, and there are things we can do to help them do that.
And one more question for both of you. What do you think people or patients are missing their checkups now during to the pandemic and to COVID-19? They are afraid of going to see their doctors and do their regular medical checks. What are your recommendations for these patients? Dr. Rula.
Do you want me to answer?
Yes, yes.
Okay, so actually, maybe initially only during the lockdown and quarantine, but patients with the chronic problems like diabetes are actually coming to the clinic to be checked.
Okay.
They are, because of what we have spread the news that patients with diabetes are not at increased risk for the COVID-19 virus, but if they get the virus, they are more at risk for the complications COVID-19. And because of that, they need to keep the blood sugar control under control. And so because of that message, I'm seeing patients more and more in my clinic. Actually, even patients who have not been to visit for like years because they're afraid. So the pandemic actually.
Oh, great. This is a positive thing.
Yes, it's a positive for diabetics. For
Yes,
diabetics.
Good. And Dr. Hiba, are you seeing more your regular patients are coming for their regular checkups as they were before the pandemic?
I have to say, initially everyone was afraid and they were concerned. The nice thing is we have things to offer them at home even. They can check their blood pressure at home with home monitoring. They can check their glucose readings at home. And blood tests, they can actually have a drive-through blood test or a test that's done from home. So in our specialty where you can offer support by telemedicine, it really helped us. But I think now people have came to a more calmer state and they're coming for checkup. Initially, we were concerned that patients will present really late in their diseases and have a COVID-related problems, not because from COVID, but from delay of seeking medical attention. Initially, it happened, let's say in March and April, but not now anymore.
So thank you, doctor, for your time. It was a very informative session. Thank you. And hopefully we can have another interview soon for other breakthroughs coming up in the future.
Thank you.
Thank you.
Miriam.
Would you like to add anything at the end?
Yeah. Okay, go ahead, Hiba.
And Dr. Hiba.
I want to add just a small piece of information. Every year in March, there's the World Kidney Day where we focus on screening and education. And that's one of the venues where we can actually educate patients about it. It's on March 11th. Maybe we'll have such a meeting again, highlighting kidney disease in general, in also together with diabetic kidney disease. So this is one of the things that the International Society of Nephrology had done to spread the education and awareness about kidney disease.
Yeah,
and thank you so much for this interview.
I would like to say, well, it's the same thing. We have on the 14th of November, we have World Diabetes Day, and it's a big day all over the world where we actually celebrate the birthday of Professor Frederick Banting, who actually discovered insulin. And so we screen patients everywhere. So this is one way of spreading the news about diabetes. And I want to say at the end, just like Dr. Hiba said, our patients are bright and smart. We have to talk to our patients. We need to talk and talk and talk. Patients should not come to the clinic to fill the scripts and leave. Patients listen to the doctor. And we have to talk to them, and we have to actually communicate and educate together the primary care physicians, because most of the time patients might actually see them first. So this is one way of educating or spreading the knowledge about the cardiovascular and renal disease complications that accompany diabetes.
Great. Thank you, doctor. It was nice having you.
Thank you.
Bye.
Thank you.
See you.